So you mentioned SCDs. Were there any other big unlocks, like when you were, I don't know if you can take yourself back to a stage of the procedure or just doing diagnostic lymphangiography, when things that you've learned along the way that have like streamlined your process or your equipment, or like how everyone's ready to go as far as, you know, making it an efficient procedure?
Absolutely. I think what I've started doing is I've changed jobs over the years. Is I always meet with my team in IR and I go over it and I show them what the setup is. I just bring in like olive oil or something and do it with olive oil just to show them what it looks like, what to expect, and to make sure that everybody knows where all these different things are in the department. Because how often do we use 9 centimeter long 25 gauge needles, or if you want to use 27 gauge or whatever gauge, it doesn't matter. The other things that I've really done is figuring out your inventory, to your point, making sure that things are all compatible. At different times there's always been back ordering of one thing or another. Most recently it seems like some of the 1cc medallions have been out of stock, for instance. So I always have a backup plan, or we use a 3cc or whatever. As I've gone along, I've realized a few areas where people tend to mess up, and one is when we load the dye in the syringes. If you're a little bit sloppy in how you do it, some of the dye can spill around the hub, and over time it erodes the hub and it may break it. If you're using polycarbonates and you draw it up using either, a longer needle or something, and make sure that it doesn't overflow, and you do a connection that isn't necessarily wet to wet, and then purge all the air out, those things will actually allow you to use it for many, many, many hours without an issue. And then I just take dye all the way through my 3-way, my 1cc and my 10cc setup, and across the tubing down to my needle. The 25 gauge 9 centimeter needles have an inner stylet similar to Chiba style. I take that inner stylet out and I connect it so that if you put the needle into the lymph node, you don't have to twist the tubing to the hub after you've already accessed it. So it's ready to go. And then I give that patient just a little wheel with a 25 gauge needle of lidocaine, and then I go through that, and I start maybe 3 to 5 centimeters away from the lymph node, and I try to angle in the actual lay of the lymph node itself so that the needle is going across it, and then I check it in an orthogonal plane to make sure I'm not off to one side or the other too much. Okay. And I do a small little injection, 0.1 cc, and I'll watch it with fluoroscopy. And even that 0.1 cc, it should start to move through the lymphatics. As little as half a cc is going to actually go from one lymph node to another. It really doesn't take that much. So you want to make sure you're getting a nice transmission through your lymph node, that you're not getting too much spillage outside of it. A little spillage isn't a big deal. But then B, you start to understand how much pressure it takes. And it really doesn't take much in that 1cc syringe to get some of that lymphatic dye to go from your access point to the next nodal stations. So it's just starting small and low, checking with fluoroscopy. If you're having trouble seeing it, take a spot radiograph. I mean, the amount of visualization of, 0.1 cc of dye, it's not that much dye. So, I just make sure that things are well there. And then I tegaderm my needle down. If I need to put 4x4s under it to keep it in that same plane, I do that, tegaderm it down, and then just keep that slow injection.
What is the location of the lymph node that you're aiming for exactly? Like for someone who's never done this?
What I typically do is I'll take a look along the greater saphenous vein and the saphenofemoral junction. There's usually quite a few right around there. Obviously, I want to access a lymph node below the level where there may be any issue.
Of course.
In a typical lymphangiogram, to get a nice pelvic lymphangiogram, right around the GSV is kind of your money ball. Okay.
And then, but the actual specific part of the lymph node where the needle is supposed to hit also?
Fair. That's a very good question, because I think, a lot of people focus on trying to get, I want to get a perfect loop between in the center and the cortex, the hilum, etc. I really just try to go across 3/4 of the lymph node. Okay. So I really tried to do it in long axis, and that's why I then check in an orthogonal plane to make sure I'm not off one way to the other. And that way that if you have any backflow along your needle, hopefully it is exiting through other efferent lymphatic channels before it spills out into the tissue around the lymph node. And I will say this, not necessarily the largest lymph nodes are not your friends.
Really?
They may be a big target.
Sure.
But there may be something pathologic about that lymph node. There may not be transmitting as effectively as sometimes smaller lymph nodes. And the other thing I'll say is that the ultrasonographic appearance of lymph nodes may change based on age, underlying disease processes, or potential treatments that they're on. Sometimes you have to get used to, is the hyperechoic, hypoechoic appearance, or is it just one that's rounded and hyperechoic, etc.? So I think, it really pays to just do a good quality ultrasound of the vicinity in and around the saphenofemoral junction. You need to go above around CFV and or below, and take a look at what's going on to kind of understand what's going on in that disease process. And to that end, it's very common for me to take a look at a patient's prior imaging. Everybody almost has a CT that has any kind of, that's been through some type of surgery, right? And often, typical abdomen pelvis CT goes all the way down to, the top third of the thigh. So you've already imaged that whole area you want to see. You can get an idea what the lymph nodes look like, where the surgical clips may be, etc. And make sure that there's no, AAA, or if there is, what's going on, if there's an aneurysm or horseshoe kidney and things like that you wouldn't be able to see fluoroscopically necessarily. So those are the things that I'm really looking for in terms of the abdomen and the pelvis. But in and of itself, just taking a look at what you would expect the lymph node pattern to be and where the stations are really gives you that heads up before you go and do that ultrasound.